Okay, we will go ahead and make a start here. Hello, everyone, and welcome to this Lab Talk event brought to you by Diaceutics. We are thrilled you have taken the time to join us today, and we look forward to bringing you more speakers and events through this precision medicine and solid tumors virtual space in the coming. Today, we feature pathologist Dr. Amy Lee from Harvard Medical School and Massachusetts General Hospital, who will be discussing the power of fine needle aspiration and core biopsy for tumor diagnosis and biomarker testing. Here's our agenda for today. My name is Justin Lehman, DXRX Lab Relations Team Lead with Diaceutics. I'm going to give you a brief introduction to Diaceutics as well as our precision medicine platform for labs called DXRX. I will then hand things over to Dr. Lee for her presentation, and finally, we will dedicate some time to answering your questions. So to begin, Diaceutics is a data analytics and end-to-end service provider specialized in precision medicine. Our mission is better testing, better treatment. We are striving for a future where the testing ecosystem enables all patients to receive the appropriate treatment at the correct time. So we believe that labs need to be involved earlier in the precision medicine decision-making process. We have experience in 96 different disease pathways and have worked on every precision medicine brought to market with 36 of the top 40 pharmaceutical companies. And we have a global presence across 53 countries, enabling knowledge sharing across a vast range of topics. All shapes and sizes of diagnostic laboratories find benefits of being registered to DXRX, and we see our lab collaborations and our offerings having a positive patient impact around the world. We seek to break down any barriers in the lab community at a global level, and the best way to do this is to allow labs access to the precision medicine platform DXRX. So DXRX membership enables you to be the first to hear about exciting sponsored scientific studies and DXRX collaborations, be a part of our data-driven recommendations to increase your visibility to precision medicine stakeholders across the globe, and access to lab talk and lab webinar recordings, precision medicine reports, biomarker reports, and our quarterly DXRX Live newsletter tailored specifically to labs. Following this live event, we encourage you to navigate to the exhibit hall to view the DXRX booth for more information, and we encourage you to sign up for DXRX today to become part of our laboratory network. It is now my pleasure to introduce Dr. Amy Lee. Dr. Lee is the Associate Professor of Pathology at Harvard Medical School, and she practices at Massachusetts General Hospital with expertise in cytopathology as well as breast and pulmonary surgical pathology. She has provided training and education in palpation and ultrasound-guided FNA techniques for many years, including authoring a chapter for the Cibas Cytology textbook, and is a former director of the pathology-run MGH FNA Biopsy Clinic. She recently chaired the Reimagined Cytopathology Task Force for the American Society of Cytopathology and now serves as the vice chair of the research committee. Dr. Lee is a co-author in the upcoming World Health Organization Blue Book on breast cytopathology and has published in breast, pulmonary, and lymph node pathology. In addition, she is on the leadership panel as an expert pathologist for the US FDA's high throughput truthing project for breast cancer tumor infiltration lymphocytes. We're thrilled to have you with us today, Dr. Lee. The floor is yours.
Thank you so much, Justin. So welcome everyone. For today's session, we are going to talk about the power of FNA and core biopsy for the purposes of tumor diagnosis and biomarker testing. These are small and mighty methods of sampling tissue, and our learning objectives for this session are to review the characteristics of small volume biopsies of these two types. We're going to look at the advantages and limitations of such small samples for diagnosis in several organ systems where they are commonly utilized, namely lymph node, thyroid, and lung, and ultimately gain understanding about how we can optimize appropriate and judicious sample selection for ancillary testing for diagnostic purposes. typically small biopsies are utilized for disease diagnosis, clinical management of patients, and triaging their diagnostic algorithms. But they are also used for retrieving tissues, for subtyping a lesion and selecting therapy, and less commonly, monitoring response to therapy is a small biopsy appropriate task. Also, a lot of clinical trials utilize small biopsies to enroll patients, and of course, we have a lot of research agendas that can be accomplished with small samples. So what exactly are these two methods of biopsy? With core biopsy, you're using a needle, and by definition, it's been traditionally accepted that a core biopsy is larger than a 22 gauge needle, and it can be tissue obtained using image guidance or palpation guidance. And because of the size of the needle, you typically have tissue that is architecturally intact. They're in small fragments, but they're all held together because you're capturing a lot of stroma in between lesional cells. In contrast with fine needle aspiration biopsies, those use a needle that is much thinner. They are defined as 22 gauge or thinner. They're also able to be guided by imaging or palpation. However, because the needle is really thin, the tissue you obtain is quite fragmented. And often, when you are preparing these harvested samples by FNA for a visual assessment by the pathologist, you are smearing them on a slide, so it causes additional fragmentation because you're trying to achieve a monolayer on the slide. So you typically do not have intact architecture, and you don't have a good grasp of the environment of a lesion. More recently, we've started to see things that have been termed cell block compatible biopsies, or CBCBs, and these are fragments of tissue that are obtained using a needle whose diameter is right on the border between a core biopsy and an FNA. So typically a 21 gauge, a 22 gauge, in that vicinity. And what this type of thin needle yields is, as you may imagine, small and very friable fragments where you do have some tissue architecture, but it is typically quite limited. And it's not really clear which subspecialist, whether it be cytopathology or surgical pathology, is better equipped to review these types of small samples. But as we go through, I'm hopefully going to convince you that this is quite amenable to all sorts of ancillary testing, regardless of who looks at these samples. So let's start with looking at the lymph node system, and we'll start with a clinical vignette. This is a true story of a patient, 59-year-old woman with cervical adenopathy. She presented with multiple enlarged nodes for a month, and the sizes of the node were up to 2.5 centimeters. She, of course, was treated with antibiotics as appropriate. She went through 2 rounds of antibiotics, and there was a mild reduction in the size of these nodes. And at that point, surgical excision was recommended because these nodes did not resolve. So her background was that she was a nurse in the OBGYN ward of her hospital for over 20 years. And she really wished to avoid excision because she knew that there are risks with surgery. And she, in fact, wanted a small volume biopsy. So she found me on the web and saw that I was a specialist in FNA, and she requested that she fly over 1,000 miles away for an appointment with me. I convinced her that she could probably get what she needed to have done closer to home. So we worked through the logistics of selecting a good practice for her to get this. So she went in, and they saw the 2.5 centimeter lymph node in her neck. They also found these other smaller nodes next door, And for some reason, they sampled the smaller node. This was a 0.6 centimeter node that was sampled, and not surprisingly, came back as non-diagnostic and acellular, at which point, again, excision was strongly recommended to her. So this patient was very much against getting an excision. So she pushed for a second small biopsy. And at that point, she had an FNA and a concurrent core biopsy of the larger node. And the pathology diagnosis top line was non-diagnostic necrosis. At that point, she was referred to infectious disease. She was in clinic with her infectious disease physician, where the ID physician read out her report that said, in the comment, necrotic cells positive for CD20, suspicious for lymphoma, which is completely different and put her on a very different clinical trajectory than what had sent her to infectious disease. So at that point, the patient underwent a second core biopsy at her insistence with a touch prep. She was ultimately diagnosed with DLBCL. She was thrilled to have avoided surgical excision, but it did take her 6 months to get biopsied and diagnosed because there was so much resistance from all the clinicians that she was seeing. And she eventually transferred to another institution to get all of her chemo and now has no evidence of residual disease. So this case was a really great example of the clinical team pushing to avoid small volume biopsies. Now, why would they do that? Well, clinical guidelines strongly discourage FNA and core biopsy for diagnosis of lymphoma. And the NCCN guidelines here explicitly state that excisional or incisional biopsy is the preferred sampling method, and specifically says an FNA alone is generally not suitable for initial diagnosis of lymphoma. They further go on to state that grading cannot be performed on an FNA, and they want hematopathology review of all cases. Now, as we know, B-cell lymphomas encompass a very long list of different entities and actually has gotten longer with the WHO 5th edition as compared to the prior 4th edition. And thus, many ancillary tests are typically utilized to provide a specific actionable diagnosis. And each type of lymphoma can have different requirements when it comes to definitive diagnosis. So in the case of Hodgkin, for example, a diagnostic assessment based on FNA is generally insufficient. Now, this seems reasonable given that we know there are pitfalls in diagnosing Hodgkin lymphoma on FNA. However, even in the case of CLL, SLL, an FNA or core is still not considered suitable for initial diagnosis of CLL, SLL. And this is interesting because one could argue that clinically you may be able to reach this diagnosis without performing an excision if you have a core or an FNA that is immunophenotyped like CLL, SLL, and the patient has peripheral lymphocytosis that flows like CLL. So there's a lot of resistance to using a small volume biopsy for lymphoma diagnosis. However, one of the things we have to consider is that only a very small subset of lymphadenopathies turns out to be caused by lymphoma. And yet, many of these cases, a small volume biopsy like FNA or core biopsy is the frontline sampling technique. So pathologists play a really important role in at least triaging care for patients if they turn out to move on to excision. And if beyond just triaging them, if we're able to provide a specific actionable diagnosis for them on a small biopsy, that would be a win for everyone. So it's with this in mind that the WHO codified a structured method for reporting lymph node cytopathology. And it uses 5 diagnostic categories of insufficient, benign, atypical, suspicious, and malignant. And each of these categories is associated with a risk of malignancy that is designed to assist clinicians and communicate to clinicians what they should do next. So as a result, each category also comes with a recommendation for what steps the clinician should take next. And also we need to think about how we can achieve a specific WHO diagnostic entity, which is really the end goal to drive patient care in an appropriate manner. So the big picture agenda for the WHO, or also known as the Sydney system, for this reporting structure is to improve patient care and their clinical outcomes through the use of small volume biopsies, specifically FNA in this case. And for the first time, they are providing key diagnostic criteria in FNA for specific entities, both benign and malignant, provided by an international expert consensus. So one of the things they had to establish was whether a lymph node FNA sample is adequate. And at this point, there is no international consensus on what constitutes an adequate lymph node FNA sample. Generally, people accept that either there are no cells present or very few cells present. Some people have suggested that 40 lymphocytes per high power field in the most cellular areas be a minimum criteria, but that's still under debate and development. The non-diagnostic category is used when you have limitations in your sample that prevent you from making any sort of evaluation. So either you have no cells, or the cells are poorly preserved, like they are here, where they're extremely crushed, or show air dry artifact, they're obscured by blood, etc. And so the WHO system allows you to use the non-diagnostic category where you don't have good lymphoid material, but also even if you do have good lymphoid material and it has enough cells that meets that adequacy criterion of 40 cells per high power field, you could still call that non-diagnostic if those findings don't explain the clinical picture. So there's some ambiguity as to whether these should be called non-diagnostic or benign, because some people would call that benign and then add a note that says sample may not be representative. Whichever path you choose to take, you should select one term consistently for clear communication, and always correlate with imaging and clinical findings in your triple test. The next category, so with the non-diagnostic category, you could recommend a repeat FNA, and at that time perform rows if possible. So that way you can triage material if needed. If you have core biopsy available at that time, that may be an option to consider as well. If your sample at the time of rows is still non-diagnostic, you should definitely make an effort to rinse your needle so that you can try to flow that material or make a cell block with it. You can actually reduce your non-diagnostic rate by rinsing your needle and trying to capture all the cells that are in the sample. So in this study, recently published, there was a rows performed on lymph nodes and thyroid, and they found that for lymph node, performing rows reduced the non-diagnostic rate from 20% down to 12%. So rows can really help you improve your non-diagnostic rate. So you would use the benign category for lymph node FNA if the sample is unequivocally benign. And you don't have to have a precise diagnosis. It would be great if you could, for example, call something hyperplastic or granulomatous inflammation, maybe identify a specific infection through routine or special stains or PCR. But most of the time, people will accept it as benign, and helpful, and hopefully you'll be able to provide some sort of idea of what is going on to cause that lymphadenopathy. Potentially, you may run into a problem where it looks like a mixed population that looks like follicular hyperplasia, but you may, in the back of your mind, wonder if it's a follicular lymphoma that's a low grade. That could be a difficult morphologic differential. Also, if you encounter EBV infection, that could be very difficult to distinguish from Hodgkin lymphoma. And then another scenario that could be difficult would be a partial involvement of a lymph node by a low-grade lymphoma. So whether the cytopathologist calls these benign or atypical depends on their individual skill and the practice environment. So some of your practices may seem more infectious and inflammatory processes, in which case you get very good at distinguishing when something is actually worrisome for lymphoma versus just a very, very reactive lymph node. So if the findings raise the possibility of lymphoma, do not use the benign category. Always move it to atypical, or if you can, move it further along in the categories, which we'll talk about. So when you are wondering about malignancy, you are going to be in at least the atypical category. So predominantly, you're worried about something low grade, usually, but you're just seeing minimal features, and either the quantity or quality is not enough for you to go any further than atypical. But there is something that is making you pause and preventing you from calling it benign. And so, for example, in the image on the right, this was a paucicellular sample with a few small lymphocytes and a few large lymphocytes that looked potentially atypical. And this patient had a history of DLBCL. And so, in a patient with a history of DLBCL, you worry about missing a recurrence. And so this was something that was called ALUS, atypical lymphoid cells of uncertain significance or undetermined significance, because there was a concern for lymphoma. If you had concern for a non-lymphoid neoplasm, you would use AUS and describe the features that you're seeing, present your ideas in the report for what your differential diagnosis is. And you should avoid using the atypical category as a garbage can diagnosis in order to allow the benign category to have a high negative predictive value. This is a cellular sample that was called atypical. So this had a heterogeneous lymphoid population with lots of germinal center fragments, dendritic cells, tingible body macrophages that would very suggestive of reactive follicular hyperplasia, but there was no flow cytometry available to confirm this was a polytypic population. So something like this you can call atypical and say that it's suggestive of follicular hyperplasia and recommend repeat sampling with flow if that lymphadenopathy persists. You would move on to the suspicious category if these morphologic features you're seeing are even more concerning for malignancy. But again, you're going to have a limited quality or quantity of findings that prevents you from moving into a definitive malignant diagnosis. Calling something suspicious should have a very high positive predictive value for malignancy for both lymphoid and non-lymphoid neoplasms. So this picture is an example of a case where the patient had a background of small lymphocytes and then one very large and atypical looking cell, and the severity of this atypia was the basis for calling this suspicious. And then malignant category is used when it's an unequivocal set of features that you could call this malignant without any ancillary testing, and there really should be very, very low false positive rates for this. And you should try to do your best if you have a material for ancillary testing to move things from the suspicious to the malignant category if you can. So using this structured system of reporting, cytopathologists and pathologists in general who look at cytopathology samples, they're actually doing a really important job of separating out what patients are in need of further workup and which patients are at high risk of malignancy. And here's a survey of multiple studies from around the world looking at the risk of malignancy associated with each of these categories. And there is a range for each category. So for example, if you look in the benign category, you have a very, one of the studies is risk of malignancy is less than 1%, and another study is 11.5%. So you do see a range, but this is going to be expected because every practice is very heterogeneous, and so you have a different patient populations that are being examined, but also slight differences in the way cytopathology is practiced. But even given these differences, you can see that as you move from the benign to the atypical to the suspicious and malignant categories, that cytopathologists are doing an extremely good job of parsing out which patients need additional follow-up. So we play an extremely important role in diagnosing patients, and we're doing it extremely well, even without any additional huge changes in the way that we've been doing this. You'll notice that the suspicious and malignant categories actually perform very similarly. They're nearly equivalent in their ability to predict risk of malignancy, which is quite interesting. So subtyping lymphoma by cytomorphology is something that was raised in 1999, and this is when I was around the time when I was in training, and I saw this picture and I thought, wow, I really can't tell the difference between the clumped chromatin of mantle cell and the clumped chromatin of SLL. So, this is really not a good way of subtyping lymphoma, which is the ultimate goal. Morphology is still useful, of course. For example, if you see follicular tissue fragments, they are more often associated with follicular processes, including reactive follicular hyperplasia and follicular lymphoma. And of course, we look at cell size of lesional cells to think about whether we're in the small cell or the large cell lymphoma category. But immunophenotyping really is necessary for diagnosing on small tissue samples. And this should now be routine. So this study was published about 2 years after that morphology real system review. And at that time, incorporating flow into lymphoma diagnosis on cytology was not being performed uniformly. They found that the overall positive rate for diagnosis of lymphoma by flow was 77%. There was a false negative rate of 0. And the positive rate for diagnosis of primary lymphoma, so these are initial diagnoses, that was 74%, so quite high. And the proportion of subclassifiable lymphoma cases increased from 61 to 77% after you incorporate flow into your cytologic diagnosis. So the ability to subclassify a lymphoma ranged from 28 to 100%, and it really depended on the type of lymphoma that was in question. But many of these can be subtyped. And this variable adequacy of flow for diagnosis based on lymphoma type was also found by others, including this more recent paper from 2020. Not surprisingly, they found that when flow was not adequate for diagnosis, it involved cases of large B-cell lymphoma, Hodgkin, DLBCL, and high-grade B-cell lymphomas. But importantly, the adequacy of flow was not dependent on the anatomic site or the FNA biopsy technique. So small volume biopsies are really quite able to diagnose most lymphomas in both the primary setting and in the setting of recurrence. In this study, all cases were reviewed by hematopathologists, but of note, none of the NLP Hodgkin lymphomas were successfully diagnosed by small biopsy in this study. And a study from Stanford showed that they also had difficulty diagnosing NLP Hodgkin by FNA in the primary setting, but they were usually successful in the rule-out recurrence setting. Although FNA utility for NLP Hodgkin is limited, and you may say, FNA is not good for this, it's actually a rare and indolent disease, so it's not something that would need immediate therapy or intervention. And you could afford to wait a little bit to repeat sample the patient. So one of the important things to consider when you're looking at a study is whether it is multi-institutional or if it's single institutional. And multi-institutional studies are really should be given more weight, and they're very useful to show the ability of small volume biopsies for diagnosing lymphoma. At MGH, we are part of a multi-institutional group called CHIC. We look and have examined a number of issues and published papers, most recently on follicular lymphoma diagnosis using small biopsies in the primary recurrent setting, as well as for identifying histologic transformation. And we found that the mean number of biopsies per workup was 1.7 for initial diagnosis versus transformation and recurrence being at 1.1 and 1.2. The proportion of workups that needed multiple biopsies was highest for patients undergoing initial diagnosis at 59%. The rate of needing multiple biopsies was much lower in the transformation and recurrence groups at 9 and 15%. But interestingly, the addition of cell block to FNA did not significantly contribute to the diagnostic yield of FNA in our study. For the purpose of initial diagnosis, a complete WHO diagnosis was reported in only 39% of workups, and this understandably correlated with an increased frequency of needing more than one biopsy. A complete WHO diagnosis was reported in 62% of transformation cases and 48% of recurrent cases, but there was a very low rate of multiple biopsies, suggesting that one biopsy might be enough for clinical decision-making in these scenarios. The overall rate of repeat biopsy was low in the rule-out transformation and rule-out recurrence cases. When we look at the cases where transformation was positively diagnosed at the end of a workup, 19 needed multiple biopsies. Additional biopsies were more likely to be needed if the workup started with an FNA with 36% frequency, compared to 12% if the workup started with a needle core biopsy. And when we look at the cases where recurrence was positively diagnosed at the end of a workup, 9% needed multiple biopsies, whereas 20% needed additional biopsies if they started with FNA, compared with 4% if they started with needle core. So we also consider the impact of performing concurrent flow in these cases. The frequency of sending a sample for flow was relatively high for all three clinical purposes, and most flow specimens were adequate for analysis across all biopsy types and clinical indications. But interestingly, the highest flow adequacy rate was observed in workups that started with FNA, whereas the lowest rate of adequacy was observed in needle core biopsy. And we saw a similar rate of repeat biopsy across all clinical indications. So the time to diagnosis and the time to treatment was not longer in the FNA group, even when additional biopsies were needed. So we can also take our FNA sample and use the material we've harvested and create a cell block that enables us to stain for all of the markers that we need to subtype a particular lymphoma. And other people have also shown that, of course, cytologic material can be used for molecular studies, including PCR and FISH. And specifically, more recently, this study out of MD Anderson showed that with FNA, your samples have a higher overall tumor cellularity than if you look at when you compare that with the concurrent core needle biopsy. And this was a study that involved 100 paired samples, and the sites were mainly lymph node, lung, and liver. So FNA was a very good substrate for performing all types of analyses. So in conclusion, for the lymph node component, the FNA and needle core, they're commonly used, and they're both very safe and minimally invasive alternatives to surgical biopsy, and they're amenable for immunostaining, flow, and molecular testing, and they can be very accurate in diagnosing lymphoma and also subtyping lymphoma. Small biopsies do have a lower diagnostic yield for primary diagnosis when you're thinking about especially follicular lymphoma, and you do have a higher subclassification rate for initial diagnosis if you do start with a core. But the difference in yield for FNA versus needle core is less pronounced if the patient is already known to have lymphoma. So you can choose either type in this context because you can appropriately run ancillaries to subtype. And even though FNA has a lower complete diagnosis rate for lymphomas in the initial setting, most FNAs for both initial and recurrent scenarios, they're usually called at least suspicious. So they end up being suspicious or malignant, which per risk of malignancy, they're nearly equivalent. Okay, so now we're going to move on to thyroid, which is another commonly encountered small volume biopsy sample. And palpable nodules are found in a few percent in women and in men, but if you just randomly perform high-res ultrasound in patients, you could see an extremely high frequency of thyroid nodules. And most of these are benign. Only 7 to 15% are malignant. And when they're malignant, most of them, over 90%, are going to be some sort of well-differentiated thyroid cancer, most often papillary. And in the US from 1975 to 2009, the incidence of thyroid cancer has actually tripled. And this year, the American Cancer Society predicts we're going to see 44,000 new cases of thyroid malignancy. And you can see in this chart from South Korea that the incidence of thyroid cancer they saw over a period of a couple decades is exponentially rising, but the risk of mortality, the rate of mortality related to thyroid cancer has actually remained extremely low. And this was the same trend that was found in the United States over a 35-year period. So recently in September, this is only a few months ago, the Bethesda system for reporting thyroid cytopathology was updated to have now 6 diagnostic categories. And we'll briefly go through these. The adequacy criteria for thyroid include seeing 6 groups of well-preserved, well-visualized follicular cells, and each group should have at least 10 cells. You could also see abundant colloid or inflammation. These would serve to tell you have a specimen that you can call diagnostic. So if you don't see those, then you would be in the non-diagnostic category where there is an acellular sample, only cyst fluid, or you can't actually see the cells well because they're crushed or obscured by artifact. And if you combine cytology slides with a cell block, you can decrease your non-diagnostic rate by up to 7% in this study. Most commonly, you're going to be using this benign category, which is Bethesda 2. Most nodules, as we discussed, are benign, and so this is going to encompass your follicular, benign follicular diseases and thyroiditis entities. So this is the one where we worry about finding the AUS category, atypia of undetermined significance. The term FLUS has now been discontinued, and we'll discuss where that went. But you use the AUS category when you can't call something benign because you see some mild atypia, but you also don't see enough atypia to move it into follicular neoplasm or suspicious category. So you would subtype the type of atypia you're seeing. Is it nuclear, or is it architectural, or is it because there's an oncocyte predominance, for example? And you should be using AUS in less than 10% of all of your thyroid FNA diagnoses in order to avoid overuse of this category. This can be associated with low cellularity samples using that show a microfollicular pattern or very focal cytologic atypia. And so you can use your clinical and radiologic findings to help further refine your diagnosis. So this is something that maybe you would call atypical, has no other cells, there's just one group, and you see some degree of nuclear membrane irregularity. This could easily be called AUS by some cytopathologists. So this follicular neoplasm category is new, and it consists of cases where there's a follicular pattern lesion and only mild nuclear changes. There are no papillary structures in here. There are either no or very rare internuclear pseudoinclusions, and we expect that about 30% of these cases will turn out to be benign on excision. And if you call this category, then you can further specify that it looks oncocytic if that's what you're seeing. And the intent of this follicular neoplasm is to capture the NIFT-P cases. So that's the non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which are managed more conservatively and don't require total thyroidectomy. And so they really want to avoid having folks put NIFT-Ps into the suspicious or positive categories where clinical management is going to be more aggressive. And you would use the suspicious category if you're now worried for a malignant neoplasm, but you don't have enough quantity or quality of features to get to a definitive malignant diagnosis. Most commonly, you're going to be considering papillary thyroid carcinoma, but occasionally you may be considering medullary, lymphoma, or other. And you can add a note about what you're thinking. Maybe your differential is PTC versus NIFT-P. And then finally, you have your malignant category, which is conclusive for malignancy. And then you should further try to subclassify the tumor using ancillary testing if needed, like immunostaining or flow or molecular. So here's an example of a medullary thyroid carcinoma that you see on a cytologic preparation with smears and a thin prep. See some clustered cells as well as slightly more discohesive cells showing some spindled morphology, so ranging from epithelioid to spindled, very hyperchromatic nuclei. In this cell block was very, very scant, but it was enough. There was a very small cluster of cells that was positive for calcitonin, TTF, chromogranin, and synaptophysin that enabled diagnosis of medullary carcinoma, thyroid carcinoma. So these numbers for risk of malignancy are the current best estimates we have based on the number of surgically resected nodules. The risk of malignancy estimation, it uses a traditional method of histologic follow-up, but that overestimates the risk of malignancy, especially for the non-diagnostic benign and AUS categories, because there's a selection bias in those patients. Most of those patients won't undergo surgery. So you can see that there's an increasing risk of malignancy with each more severe level of diagnostic category. And that shows that pathologists' visual assessment, they're able to discern increasing levels of clinical concern for malignancy, even on very small samples that technically only require 60 cells to call. So with this table, you have a diagnostic category that then is correlated with a management recommendation. And molecular testing is recommended for the AUS, follicular neoplasm, and potentially Sesson malignant could be utilized as well. And molecular testing is now routine for these indeterminate categories, and you'll see that through iterations of ThyroSeq, which you've probably all heard of, as these have been validated with real-world clinical patient use in all of these 3 studies, you'll see that the positive predictive value is less than 50% in all of these, but the negative predictive value was 90% or higher in all of these. So that really supports the use of molecular testing in that the way that it's been set up as a rule in benignity, rule out malignancy type of test. So using molecular testing, it's going to be applied whenever you get that indeterminate category. And so 20 to 25% of cases in FNA thyroid are going to give you either the suspicious for malignancy, suspicious for follicular neoplasm, or AUS category. And then 49% of AUS diagnoses can avoid surgery because they're going to come back with a benign appearing molecular test. And it doesn't matter whether you use RNA or DNA RNA testing, they both perform pretty similarly. And thyroid FNA is really quite well positioned to have been taken advantage of for molecular testing, because we've known for a long time that alcohol fixation, which is the usual preservation method for thyroid FNA, is superior to formalin for nucleic acid preservation. So you could also use immunostaining on FNA samples to address your indeterminate cytology. So for example, galectin-3 expression is higher in thyroid cancers compared to benign or normal thyroid tissue. This was promising when it first hit the scene, but it's not been reliably reproducible across studies. There are other markers also being investigated for various predictive values, but also a serum galectin-3 is something others have been working on. So we can also use FNA samples to immunostain them. And as molecular testing becomes better and better with each iteration of panel that are being developed, we started out with a 7-gene panel, ThyroSeq 1.0 with 7 genes, and now we're up to 112 thyroid-related genes. So this is just only going to get better and better, and this is all based on small biopsies. And so I wanted to show this case of a patient who I saw, and I thought it really nicely illustrated the path that a patient takes for thyroid evaluation. So here's a 39-year-old woman. She had a chest x-ray for respiratory symptoms, and it was not resolving. So they thought, could this be pneumonia? We just need to confirm or rule out something else. And incidentally, at the superior aspect of the CT scan, or a chest x-ray, they saw this calcified left thyroid nodule. It was 3.3 centimeters. So they did an ultrasound, which measured that nodule to be at least 4.8 centimeters, and was actually much more worrisome here because it appeared to be exophytic and extended into the mediastinum. They called it a TIRADS-4 by imaging and recommended her for an FNA. This is the whole slide image of one of her 4 smears. It was extremely paucicellular, but you see that there are cells here. It does meet the adequacy criterion of 6 groups of 10, and you can see a microfollicular pattern here. So this was called FLUS, and today it would be called AUS with architectural atypia. And there was a request from her endocrinologist that we send this for molecular testing. And so we took that smear, we digitally archived it after scanning it, and then I selected the best smear in order to be scraped and then sent for molecular testing. The result came back positive for NRAS mutation. So she's now told she should get a total thyroidectomy by her surgeon, and she's confused. She had no idea any of this stuff was going on behind the scenes. She actually called me for a pathologist consultation. So I met with her virtually, and she had the following questions for me. First of all, she just wanted to understand what is FLUS, and I explained what that was. She said nobody told me anything was being sent for ThyroSeq, which is understandable because consent is not required for limited panels like this. We talked about what ThyroSeq means and what the test result means. She had a baseline BRCA mutation. She didn't know how this played into things. And then finally, does this mutation mean I have cancer? And this was an important question. It was really quite an important issue because we find DNA mutations in benign thyroid nodules. So in her case, she had a RAS mutation, And there are studies out there have shown that RAS mutations are found in benign thyroid nodules. You could have a reparative or benign hypoplastic condition, and you would find RAS mutation. So as far as our current estimates, we have about 15% of benign nodules harboring RAS mutations. So this was not something that was explained to her, and maybe not something we would even think about. But ultimately, she chose to go ahead with total thyroidectomy given the plethora of imaging data that we saw. And she was found to have an encapsulated follicular variant of PTC, which was minimally invasive, but it did have multifocal capsular invasion, which is something that cannot be diagnosed by FNA. And there was also RAS positivity by IHC or immunostaining that was concordant with her ThyroSeq finding. So I also wanted to just point out that in this case, we took that smear and we scraped it and sent it for molecular, but you can also scrape that smear and make a cell block for immunostains. And this has been something cytopathologists have been aware of and practicing for many years. And this idea of scraping smears for molecular testing has been shown for other organ systems and other types of malignancies as well. Furthermore, you could take the residuum of any liquid-based preparation and turn that into a cell block, and then you can perform ancillary testing on that. And finally, for core biopsies, for thyroid, core biopsies have been proposed as maybe a better or complementary technique. We tend to avoid core biopsy in thyroid because it is a very vascular organ, but it is something that people are exploring, especially out in Asia. So that is something we can keep an eye on as a possible option. So thyroid sampling with small volume biopsies is the standard of care, and it is really amenable for molecular testing, and it actually enhances the pathologist's visual assessment, which is already quite good. So we played a really important role in triaging the patient, but then we're also able to selectively convert and choose which materials get sent for what testing. And then our final organ system is lung. And this is important because the majority of lung cancer patients are unresectable at the time of presentation. And most patients already have had spread to their regional lymph nodes or distant sites. So staging is really important for the appropriate clinical management of these patients. And small biopsies are currently preferred for lung cancer diagnosis. They're minimally invasive, they're very safe, and we've had a lot of success diagnosing with small biopsy. And with these small fragments of tissue, pathologists they're under pressure to establish the nature of the lesion, but then also subclassify tumors. So up to 30% of non-small cell lung cancers require IHC for accurate subtyping. So either a cell block or core biopsy is needed. And of course, we want to preserve and triage tissues for any appropriate biomarker testing and sequencing. And many studies have shown how FNA is highly accurate for lung cancer, lung tumor diagnosis. And this is a multi-center Italian study that showed FNA was more than 95% accurate for lung tumor diagnosis. And performing ROSE is quite safe. It did not increase any complication rates for patients undergoing percutaneous biopsy. And similar to lymph node and thyroid, the management involves running your triple test, correlating your diagnostic category, which is similar to what we've talked about in the other organ systems, and comparing that with your clinical and radiologic information, and also microbiology. So multiple different NGS panels are available on the market. You may have your own lab-developed assay in-home, and that would be very good for running through, running your samples through from your needle rinses, for example. So here's an example of a fine needle aspiration with a cellular sample showing nuclei that are small and molding, and the IHC on this cell block compatible core biopsy was consistent with small cell carcinoma. But here's another case that was a little different, of a 67-year-old man who had a smoking history, had a history of laryngeal squame and urothelial cell, and now presents with a hilar mass that's quite large, and it was FNA'd. And it showed cells that look kind of like small cell, but that by IHC showed preservation of RB and loss of SMARCA4 and SMARCA2, and were negative for neuroendocrine markers. So this case really shows the importance of obtaining adequate material for immunostains and other ancillary studies, because the initial diagnosis was actually from another institution. It was called small cell carcinoma, because we know that small cell can lose neuroendocrine markers, but they did not run a more extensive panel to find that this was deficient in SMARCA4 and SMARCA2 and have preserved RB. Another thing that we can do with small samples is perform PD-L1 testing in order to see if the patient is eligible for specific therapies, and the tumor proportion score is most commonly used. So we look at the number of tumor cells with membranous staining, divide that by the total number of tumor cells, and multiply by 100, so that is presented as a percentage. And this is something that can be performed on cell blocks, but also on smears. So cytologic samples are perfect and very acceptable for this specific PD-L1 testing. So, and as we can see, smears can also be stained directly, and FISH can be performed directly on smears to identify genetic alterations. So with lung cancer patients, and as they're being evaluated, they often have multiple samples obtained from one biopsy encounter. So you can get a combination of smears, cell blocks, core biopsies, transbronchial biopsies, and there's no consensus on how these small tissue samples are handled. Some places have cytopathologists handle all of that. Some places split these samples between cytology and surgical pathology. And so each of these samples will get its own diagnosis, though. So you may be receiving a cytology report that shows cytology diagnoses, and then a surgical pathology report that has separate diagnoses. And if you could not see what the other specimen was being worked up with, you could end up having redundancy in how you are using up your tissue for ancillary studies. And so this could lead to unnecessary tissue use. You can exhaust a very small sample, and so this would not be ideal. One thing that you should consider doing is integrating these two types of samples together, so you could look at all your samples side by side and appropriately select the tissue component that you want to send. So for example, maybe you will send the cell block for a bunch of immunos, and you'll send the core biopsy for molecular, for example. You just want to reduce your redundancy. And then you also want to be able to reduce your diagnostic discordance between the diagnoses you issue for each of these parts, which can mitigate confusion for your clinical colleagues and your patients. So this was what a combined report might look like. And you'll notice that not all transbronch biopsies and core biopsies even contain good material. And just to point out again that tumor cellularity in FNA samples is higher than that of core needle biopsy. So we instinctively pull the trigger on sending core for tests. We think that's better, but it's actually not always the case. And FNA is a very pure source of material, has higher purity. And we've so far been very focused on the cellular component of retrieved samples, but we can also actually think about using the supernatant of centrifuged materials. And in this study, there was concordance of the supername with the surgical specimen in 100%, where they identified the same genetic mutations in both. And so we should consider cytology samples in all its respects, even the parts that you think you may just discard. So in conclusion, FNA and core are complementary. FNA has a higher tumor cellular purity and fraction, but core biopsy shows more architecture. And you need to weigh the pros and cons of each and then judiciously select which part you're going to send for what testing. And I would strongly encourage you to integrate your reporting of these together in one pathology report. And with that, I'm happy to take any questions from the audience if there are any.
Yes, thank you so much, Dr. Lee. It's always fun to see the case studies and learn about your expertise in this and how the different testing techniques are impacting patient outcomes. So thank you so much for your presentation. We do have a few questions that I'd like to address. I know we're a little bit over time, but we will go through some questions here. The first one is, how do you feel about limiting lung IHC to TTF1, P40, and PDL1, and using comprehensive genomic profiling to determine origin?
Yeah, that's a really good question. The WHO really wants to push preservation of tissue, and so they don't want to have us use up tissue by doing a bunch of immunostains. I think that panel, the TTF-P40, PDL1, it is basically the bare minimum you would want to do, and it is a reasonable panel, especially if the amount of tissue you have is really, really small. But that being said, you're going to run into situations where you're going to need more than that. And so I think it really depends on the specific tumor type that you're dealing with. Genomic profiling certainly is a wonderful tool, and it has helped us subtype very high-grade, poorly differentiated tumors, where there was one case in my memory that we were thinking was mesothelioma. Like imaging showed mesothelioma, like plaques along the pleura, for example, and then didn't seem like there was a primary lung mass, and it was not staining for anything. And then just based on imaging and the morphology, we're just like, well, it's probably mesothelioma, and called it mesothelioma and sent it for profiling, and it came back EGFR positive, or positive for mutation EGFR, which meant that this was actually a poorly differentiated lung adenocarcinoma. So I think if you're dealing with something that's relatively well differentiated, TTF1 P40 is going to be enough, but certainly you run into situations like undifferentiated SMARCA4 tumors, and they're not going to be enough. So I would say like starting with a limited panel makes sense, and then moving on to a larger panel if needed. Sorry, the light in my room just turned off. So
That's okay. Thanks, Dr. Lee. So another question we have, you mentioned a little bit about integrated or combined reports. So do you use integrated and combined reporting for concurrent cytology and core biopsy specimens?
We do for lung specimens, and the reason is because the clinicians, the pulmonary surgeon, thoracic surgeons, and the pulmonologists felt very confused with split reporting, because there would be lymph nodes coming from the mediastinum when they were doing the Cibas, and then there'd be a transbronch biopsy that would go to SurgPath, and they would be reported separately, and they were very confused. And then navigating Epic, our online portal, just very confusing to them and exhausting. There's a lot of fatigue trying to go through all these reports and then putting everything together. So they actually supported us integrating our cytology and surgical pathology diagnoses into one report. So that was something that came about because of clinician request to ease their burden. And so we do it for pulmonary. We don't do it for any other system. We are fully subspecialized here, but we don't do it for any other system. This is something that may, evolve over time and involve other organ systems.
Very nice, thank you. And then one final question for you, Dr. Lee. Do you utilize any particular practices with lung nodule samples to support maximizing diagnostic yield on limited samples?
Yeah, so we typically take our tissues and we put them in, we like sort of spread them out over multiple slides. So if you get, for example, 3 fragments from a lung mass, they do a core biopsy and there are 3 fragments. We put each fragment into a different cassette, so it comes out on a separate slide, and then we are able to pick which one we want to send for molecular and which one we want to perform immunostaining on. And that way we get to preserve tissue and still maximize the amount of information we can get out of these. Sometimes I've actually had to go back and melt the block down and then separate it because there was very limited tissue and I wanted to maximize diagnostic yield. So that's one thing that we do in addition to combining our reporting and looking at everything together so that we don't duplicate testing.
Very good. Thank you so much for answering those questions. And one final thank you to you for sharing your knowledge with us today and being here to present. And thank you to all of you who took the time to attend this session and stuck with us through the Q&A. Please be sure to check out the DXRX booth in the exhibit hall, and we welcome you to become a lab member today. We have future sessions coming up here in the precision medicine and solid tumor space, so please stay tuned for any messages on those, and we look forward to seeing you for those events as well. Have a great rest of your day, and thank you everyone for tuning in, and one last thanks to Dr. Lee as well.
Thanks everyone. Thank you.